Hello. Good afternoon, everybody. Warm welcome to this oral abstract session. Very glad to have you here in the room, and I guess we will have also some people connecting virtually. So I'll be your moderator today. My name is Pascal Meuriset, Program Officer at UNAIDS. So very happy to be here with you. Today we'll be talking about social determinants of health. We have a packed agenda with 7 speakers, so I won't take much time now. And I will already give the floor to Christoph Weber, who is with Checkpoint Berlin. And he will be presenting his abstract on high burden of blood-borne viral infections, HCV, HIV, HBV, and sexually transmitted infections among people experiencing homelessness. First results from a pilot study in Berlin. Thank you.
Thank you. I would like to thank the organizers to give me the opportunity to present this data on the Fast Track City conference here in Sevilla. I would start with the background. It is estimated that more than approximately 400,000 people in Germany are affected by homelessness in 2018, and the trend is rising. People experiencing homelessness are affected by social exclusion and poverty. They live in precarious living conditions with associated risk factors such as alcohol, drug use, imprisonment and sexual risk behavior, and no or limited access to health care aggravates the situation. However, there are still no special testing and prevention services for people experiencing homelessness. Furthermore, there is no data on infectious disease in those population in Germany so far. So we conducted a pilot study to assess the accessibility to this specific population to determine the prevalence of HIV, HCV, HBV, and syphilis and other sexual transmitted diseases. Participation in this study was completely anonymous. The data were collected during the pandemic in May and June 2021. In order to be as close as possible to the population, the data collection was linked to 5 different acute care facilities on the homelessness services in 5 different districts in Berlin, as you see in the picture. Participants were approached at the local level and were eligible for the study if they were over 18 years old, were homeless and gave their consent. Okay, we conducted a questionnaire-based interview. With 86 demographic, behavioral, and health-related questions. We took venous blood samples for antibody testing for HIV, hepatitis B and C, and syphilis. And we collected urine samples to test for chlamydia, gonorrhea, and using NUT, and offered a physical examination. 216 participants were included in the analysis. The mean age was 41 years old. 88.4% were male, 50.5% were rough sleepers, 60.8% experienced homelessness less than 3 years, 54% origin from Eastern Europe, and most of them origin from Poland, 56% or almost 57% had no health insurance. So we looked for drug use, and 72% reported having used drugs at least briefly in their lifetime. 47, so almost half of the participants, had intravenous drug use in the last 13 days. 71% had been imprisoned at least once in their life, and 48% had their tattoos done on a non-professional setting. 58% of participants had been sexually active in the past 12 months. Of those, 73% reported having unprotected sex, 35% had more than 2 sexual partners, and 6% reported being engaged in sex work. So focusing on the results of the blood-borne and sexual transmitted infections, 23% had a positive HCV antibody test, of which 16% had replicative HCV with detectable HCV RNA. Hepatitis B surface antigen was detected in 2% of the participants, and HIV was reactive in 3%, representing 6 participants. All of them knew about their status, but only 3 of them were on treatment. The others were without treatment due to lack of health insurance status. Sexually transmitted disease were found in 6% of the participants, with 1 double infection of chlamydia and gonococcus. Compared to the prevalence of these infections in the general population, in Germany, we found a high burden of blood-borne and sexual transmitted disease in the participants of this study. So we are coming to the conclusion that there is a need to improve awareness and access to treatment and care for this population group. Networking between addiction, homelessness, and infectious disease services need to be strengthened. HCV prevention and elimination efforts must be supported and strengthened for this population group. And furthermore, we propose to extend this study to other cities in Germany to verify the results. So I would like to acknowledge the cooperative teams of Robert Koch Institute, Fixpunkt, a local institution for ID drug users, Checkpoint Berlin, and BESOC. Without their dedicated contribution to this study, it wouldn't be possible. And of course, a special thanks goes to the participants and the medical facilities of the homelessness service. It was a pleasure working with you. Thank you.
Thank you very much, Christoph. Next is Joshua Wharton from George House Trust in the UK. Joshua should be joining us online. Not yet, okay. So we'll go to the next presentation and then we'll come back to Joshua. So next is Miguel Ramiro from the University of Alcalá. And Miguel will speak about legal drivers to eradicate HIV-related discrimination in Spain, and he has a pre-recorded message. If we can start from the beginning, please. ¿Puede empezar el video? Sí, desde el inicio. No, pues el video primero. Gracias.
Hello, and thank you for having me today to present you this research on the legal driver to eradicate HIV-related discrimination in Spain. This research is part of a consortium between Ministry of Health, CESIDA, and the University of Alcalá. Legal determinants are a key element in the building of a response to HIV based on human rights. Legal system affects in a positive or negative way on the health of people with HIV. In Spain, in 2018, the Social Pact for Non-Discrimination and Equal Treatment associated with HIV was passed, and among the action included in the Social Pact was to identify those legal drivers that affect people, affect rights of the people with HIV. The Social Pact is in alignment with the latest political declaration on HIV and AIDS declared by the UN General Assembly. Among the latest legal drivers in Spain is the Act 15-2022, This is an important act as legal driver to eradicate HIV-based discrimination because, first, the serological status is included as a non-discrimination ground, and second, assign to NGOs the legal capacity to initiate legal action in case of HIV-related discrimination. Our research is based on the cases sent to the HIV legal clinic at the University of Alcalá. We have identified different keywords that we have used in the main legal databases in order to identify the legal rules, the legal driver that can affect the rights of people with HIV. We have focused on the years 2019 to 2021 because is the 3 years period in where the social path is valid, and also some legal reforms were passed in Spain. This is our concept of discrimination. Is a concept of discrimination is a classical one that you can find in most case law in Europe and around the world. And these are the 3 phases of discrimination that we have found in the Spanish legal system. The direct, the indirect discrimination, and by association. I mean, it's when it is not the person with HIV who is discriminated by those persons that are related to a person with HIV. Our results. To date, we have identified 209 legal regulations at national, regional, and local level that could affect rights of people with HIV, and we have divided this in good practices and some cases that are discriminatory. Some of the good practices highlights at the state level, it's the elimination of HIV as exclusion criteria in access to state security forces and the army. This was at the end of 2018, but the public access was in 2019. At the regional level, there are some autonomous community that have included, in this case Catalonia, has included the serological status as a non-discrimination ground. And at the local level, in the city of Seville, we can find grants to non-profit entities that develop projects for the prevention, promotion, and protection of HIV and people with HIV. And some highlights in the discrimination based on HIV. At the state level, people with HIV are excluded from access to private security forces. That is in my opinion, a nonsense, because they can be part of the army, but they cannot work as private bodyguards, for instance. At the regional level, in the community of Madrid, people who live with people with HIV are deferred as blood donor. This is the concept of living with. It's not, they are not having any sexual intercourse or intimate contact. Maybe they are just sharing a flag. And at the local level, the requirement of infectious contagious disease in the access to the profession of taxi driver. It seems that there is an agreement in the Council of Seville saying that people with HIV can be taxi drivers, but we have not been able to find this agreement, but we are in contact with the town hall of Seville to try to know if it is possible to get access to this document. I would like to present you a case study that it is the access to insurance in Spain, that it is a very interesting case because in 2018 the Act on insurance contract was amended prohibiting the discrimination of people with HIV when they have to buy this health insurance or life insurance. Since the reform of the the Act on insurance contract, the number of cases that arrived to the HIV legal clinic at the University of Alcalá increased, as you can see in the graphic, from 14 to 44 in only 12 months. But despite the legal reform, discrimination in the insurance field is on daily basis because there are not effective instruments to protect the rights of people with HIV. And this could be the first conclusion of our research. Legal drivers can help to eradicate HIV epidemic, abolishing the discrimination based on the serological status, building an HIV response based on human rights demands, review and reform those legal provision, criteria and practices that perpetuate discrimination, the three phases of discrimination, but also demands passing new legal instruments to enforce the rights of people with HIV, because it is not enough only to have the legal rule if you don't have the instrument to guarantee the right. Since 2018 in Spain at national, regional and local level, several legal drivers have been passed to build an HIV response based on HIV, but we have still work to be done. As you can see, reforming provision, criteria and practices, and improving right guarantees, a guarantee system. And thank you very much.
So thank you to Miguel. And now we're going back to Joshua, if he's still online. So Joshua Wharton is from the George House Trust in the UK, and he will be talking about peer mentoring support for people living with HIV, addressing the fourth 90. Joshua, are you with us?
Yeah, can you hear me?
Perfectly. Go ahead. The 10 next minutes are yours.
Thank you. Well, hello from Manchester. So yes, I'm joining today to talk about Better Together, which is the project that covers the whole of Greater Manchester. So that's 10 boroughs in total, with a population of about 2 million. And there are about 6,000 people living with HIV across Greater Manchester. And the focus of the talk today will be around peer mentoring and support for people living with HIV, specifically in terms of addressing the fourth 90s, so quality of life. My name's Josh, and I'm a services operations lead here at George House Trust, and I've had responsibility for Better Together for its duration. So Better, well, George House Trust, Greater Manchester's HIV support organisation, we're funding from the National Community Lottery Fund. A lot of charities receive funding from the lottery here in the UK, launched Better Together back in 2017. The aim of the project, which was a 5-year project, was to provide high-quality peer mentoring for people living with HIV across Greater Manchester, and that was done more broadly as part of Project 100, which is the brainchild of Positively UK in London. So there was a network of organisations across the UK doing it, and we were the sort of Greater Manchester element of it. Mentors attended a 3-day training course with us and provided support at George House Trust, in the community, and at HIV clinics across Greater Manchester. And there are 10 clinics in Greater Manchester in total. I'll talk a bit more about our experiences in clinics. Relationships were time limited and focused on goal setting and social connectivity as well. So, at the start of the conception of the project, the key areas that we wanted to focus on was improving understanding of HIV, clinic engagement and medication adherence, giving people the tools and confidence to talk about HIV, and increasing social connectivity and reducing stigma. It's worth noting that at the start of the project, we did assume that most of the focus of the relationship would be around understanding of HIV, clinic engagement and medication adherence. We anticipated that a lot of the support would link to HIV as a medical condition, with maybe less focus around the social aspects, or less of a focus around the social aspects. So that was our starting point, really. So a lot of our data that we collected was around HIV as a medical condition. Over the course of the project, so over the 5 years, we engaged 415 people. We trained 79 peer mentors. We did training about every 6 months. And there were 200 community matches over the duration of the project. We saw 65 people in clinic, which is a lot lower than we'd hoped for, and we'll talk a bit about that in a moment. But we also engaged people in other forms of support and peer support. So we engaged a local organisation around life coaching. We did a personal development programme, and we did an initiative called Catwalk for Power as a way of engaging women. And again, that was done in conjunction with Positively UK. So as the project developed, although the initial focus was on one-to-one mentoring, we moved into sort of more group and informal peer support and mentoring as well, to reflect the feedback from people engaging in the service. In terms of people we engaged, so George House Trust, in terms of support, about 50% of people we engage with are identified as LGBT or generally gay, bi and MSM men. About 30% of people are from African communities, and 20% are from other communities as well. But if you see with the figures on the screen, that wasn't necessarily reflected in Better Together. So over the duration of the project, 76% of people engaged were identified as LGBT, compared to 23% heterosexual. And that really reflects some of the difficulties we had of engaging other communities in this type of support. That lessened as the project went on, and we engaged more people from different communities more, but we found it a lot easier to engage, especially white British gay men. Potentially because there was a white British gay man leading the project, but I think it goes into more kind of cultural expectations around service engagement and what people understand in terms of the services that they want to engage with. We tried to challenge that or rectify that by running courses specifically for women, training up people from other communities to lead courses, and that did seem to have quite a positive effect by having people from your community or a community where they feel reflected leading and being, I suppose, the face of the project. So we did make some improvements, but even so, there was quite a marked difference between engagement. We also, at the start of the project, anticipated that the majority of people engaging would be newly diagnosed. We receive around 100 referrals a month, a number of which are people who were newly diagnosed. And there are about 300 new diagnoses across Greater Manchester each year. But again, through the duration of the project, we saw 43% who were newly diagnosed and 50% of people who'd been living with HIV for 12 months or longer, a number of which had been living with HIV long term. So there was a real benefit for peer support for people for the full kind of spectrum of the number of years they've been living with HIV. And quite often, actually, when people engaged initially or within the first couple of weeks or months of diagnosis, it was a bit overwhelming. So what we saw quite often was people engaging when newly diagnosed, disengaging in an unplanned way, and then re-engaging later. I think there was about 20 people who did that over the 5 years. So there's something there around people's ability to engage with this type of support early on, but that's not to underplay the importance of potentially having peer support available in clinics early on, so you can meet someone living with HIV. But yeah, we were quite surprised at the number of people who engaged with peer support, who've been living with HIV for over 10, 20 years. But I suppose the difference was maybe what people wanted from the support, what they wanted to achieve with it. Less focus on HIV, more focus on social connectivity, isolation, aging with HIV as well. So that was quite interesting. We, as part of the project, we aim to engage 10 clinics across Greater Manchester. Some are larger than others. We have closer relationships with some compared to others, some of it based on geographical location, some of it based on our history. So the aim was to run peer mentoring clinics in all 10 clinics. We had limited success in that area in terms of one engaging clinic and success when we were in clinics. So we managed to run the drop-ins at, I think, 7 clinics in total, but it didn't really work, or didn't work well. There were lots of barriers put in the way in terms of bureaucracy, but also in terms of actually rooms. So there were some kind of physical, practical barriers, and we didn't see the numbers that we'd hoped for. But in saying that, when we did get into clinics and when it did work, we did see a different demographic profile compared to people we've seen at George House Trust. So as it shows here, we saw more women, we saw more people who identify as heterosexual, and I've not got the data on the screen, but we saw more people from African communities compared to the wider Better Together project. So there was definitely a benefit from being in clinic. COVID played a part in stopping that happening, because that was around year 3, and that kind of put paid to any engagement with clinic. But we're very keen to kind of build on that, because we understand that by being in the clinics, especially those that are more geographically further away from Manchester where we're based, there's a real benefit from having someone living with HIV in those clinics. And we're actually about to launch a peer navigator pilot with Gilead, which will have a paid peer navigators to someone living with HIV in one of the larger clinics for a year-long pilot based on what's already been done in the Homerton in London, to see if that helps us to engage more people who wouldn't ordinarily come to George House Trust. In terms of, so we collected data across the sessions. There were about, I think it was 900 sessions in total over the duration of the project, and this kind of reflects what people were talking about in those sessions. At the top of that is general health and well-being. I mean, that is quite a broad area that could cover anything, but that kind of reflects the fact that actually quite often the peer mentoring or peer support didn't actually focus on HIV, because it's a holistic approach. Confidence and self-esteem came in really high, as did sex and relationships. A big surprise for us was employment. So quite often people were focusing on employment, whether that be seeking employment or changing jobs. And then you've got things like talking about HIV, but further down you've got medical appointments, managing HIV treatment, starting HIV treatment. Although it's worth saying around starting HIV treatment, at the start of the project, the guidelines were still that you commence treatment when your CD4 count is below 500. That changed quite quickly, so quite often when people come to us, they're on treatment at the point of diagnosis. So arguably there's maybe less to talk about because you're not having to build up to starting treatment. But we have found that actually the main focus has been the more social aspects of HIV, which goes to show the benefits in terms of wider quality of life. You know, people struggle to navigate sex and relationships. Confidence and self-esteem can be an issue. And also, like anyone, you know, people have issues in their life that they want to address. And to live well with HIV, it's good to kind of look at a full person's, you know, everything that's going on in someone's life. So that was, you know, quite a surprise, maybe how HIV as a medical condition was lower down. In terms of, we talked, as mentioned earlier, about it being goal-focused. So across the sessions, around 43% incorporated where someone set goals. So there was quite a lot of focus on goal setting. 21% included some form of signposting, whether that be to George House Trust or more broadly to other services. And there were only 10% of sessions that there was only a concern raised, which was something that we monitored quite closely because the support was being offered, most of the support, over 90% has been offered in community settings. So it's quite important that we reflect on any kind of issues that might arise in those community settings and have things in place, but we've not really had much of an issue on that front. It's quite rare that serious concerns or issues have been raised from a safeguarding perspective. So in terms of our evaluation and monitoring, we use 2 tools, a holistic tool, which was used at the start and the end of the service. And this was also used as a framework of discussion as part of the match meeting, where we asked people to score themselves on a scale of 1 to 10 across different metrics. Quite tricky with it. What we realized quite early on is it's quite tricky to attribute any changes to this because obviously people have other stuff going on in their life. So this is less attributable, I think, to mentoring more broadly. but he gave us a good kind of snapshot over idea of the changes that were being facilitated. Grey shows progress, purple shows no change, and blue shows regress. So thinking about when this might be done, it could be done at session 1, session 6, or session 12. Emotional health and well-being, we saw the vast majority of people reporting progress, but there was regression on the scale across all areas. I know, some people reported feeling there'd been no change. The sex and relationships and emotional health and well-being was where we saw the most progress, with the grey being much higher, averaging just below 40%. But if you look at that in compared to knowledge and understanding of HIV, this is where people reported less change. So quite often people were coming to us and telling us that actually they had as much knowledge as they wanted. There was still progress for a lot of people, but it wasn't such a marked progress compared to sex and relationships and emotional health and well-being. And we think that part of that could be because a lot of people get the information they want from clinics, or they have the resources to access that information, whether that be online or through the tools we have here. So again, it's been less of an area of focus. We also asked people to do an end survey, a service quality survey, where we asked them to attribute any change specifically to peer mentoring. So this is where we try to attribute any change to the peer-mentor relationship. And as you can see, across the board, most people report feeling more confident. And about 50% of people completed the survey. It was sent via email, and I'm sure a lot of people will know how difficult it is to get people to complete a survey once they've actually finished their support relationship. But the key areas were living happily and confidently with HIV, living healthily with HIV, and dealing with personal issues as and when they arise. So those are the ones where people, above 80% of people, reporting a change, an improvement in how they felt. But across the board, most people reported feeling more confident on all areas, including aspects around knowledge, HIV treatment and clinical engagement as well. Just a few examples or case studies of people we've worked with. So the first one is a gay man who recently sought asylum. New to Manchester, we see a lot of people in the asylum system in Manchester and people who are moving new into Manchester. He's living in shared accommodation with very limited social connections, was also exploring sexuality. So he'd moved from a country where being gay was illegal. So that was quite a big area of focus for him. Matched with a mentor, regular meetings and activities, including trips to the gay district and cinema. So we're very focused on it not necessarily just being sit-down conversations, because quite often people find that difficult. And people don't necessarily want to sit down and talk about HIV for an hour each week. So we put a lot of emphasis on doing activities or finding joy in life, especially for people who maybe have a limited income, because we do have a budget for activity. But the mentee reports greater confidence and is engaged in volunteering at George House Trust. And that's been a huge difference to that person's quality of life. And that peer mentoring relationship went on for quite a long time, much longer than some of the others. And it waited until they'd been moved out of the shared accommodation and found more stable accommodation. After we reflected on actually, we needed to wait for there to be an improvement in this person's life before that relationship ended. Another example was a recently diagnosed African woman who was matched with another African woman, matched with the same woman from the same community. They were able to explore HIV together, initially meeting at George House Trust, but move into a community setting. What we see quite often is people feel comfortable meeting at George House Trust initially, but the goal is to get out there and go to cafes, parks, areas where you can normalize talking about HIV in a community setting. And at the end of the relationship, the woman reported less fear about HIV and was able to speak to her family about her diagnosis. And finally, another example used was a woman who was living with HIV for 10 years, hadn't told anyone or spoken about it outside of a clinic. Very outdated views about HIV and life expectancy. She thought her life expectancy was 10 years. Not quite sure why that hadn't been addressed in clinic. Maybe it just wasn't brought up. But she had a young child, so was reporting a lot of anxiety because she thought that her life was, or she'd become unwell in the near future. But through her mentoring, she was able to learn more about HIV and become more confident, and is engaged in other George House Trust services such as counselling. And she now actually is one of the leaders of our women's group and is involved in some of the videos we're doing. So has gone from not telling anyone to living quite publicly with HIV and acting as a role model for life with HIV. And one thing worth mentioning is quite often in terms of recruiting mentors, it's very easy for me because it's people who come through mentoring themselves.
I'm really sorry to interrupt, but I'm going to ask you to conclude, please.
Yeah, sorry. I'll go to recommendations. So our recommendations are tangible and long-lasting benefit to the provision of peer-led support that empowers people living with HIV. People living with HIV should have access to peer mentoring through clinics, third sector organisations, or remotely. COVID-19 was really important, showed that things can be done remotely and it works. And especially mentoring in clinics helps to reach different demographics but there are practical and bureaucratic issues to consider. Formal relationship with clinics is best in the form of an honorary contract, that's specifically in relation to the NHS. Thank you.
Thank you very much, Joshua. So our next presenter is David Nell from Out LGBT Wellbeing, and he will be talking about innovative holistic approaches to improve health outcomes among socially vulnerable MSM communities. David?
Hey, thank you. Short history, Out started in 1994. We're the second oldest LGBT NGO in South Africa. We've had in the past quite a lot of successes, including we lobbied for same-sex marriage in 2006 in South Africa. We were successful with that, first African country and the fifth in the world. Our current work focuses mainly on hate crimes and human rights, and we've got a few new additions, mental health and young, focus on young people, programs that have recently started. And what I'll be speaking about is our health program that's funded by USAID, that is in 3 South African cities, including the city of Joburg, which is the biggest city in South Africa. It's quite a big program. In the last 5 years, we've provided more than 100,000 preventions. We tested over 13,000 men we placed on PrEP, and over 4,000 men on antiretroviral therapy. How we work is we have a fixed clinic, but we also have mobile teams that go into the 7 health regions in the city of Joburg. The major difference, and in South Africa and I suppose a lot in the world, our clinic is very middle class, people with very good health-seeking behaviors, where our mobile services are much more low socioeconomic men, and their health-seeking behaviors is not that good. We had a major shift in our program and major successes that we consolidated in COVID. We moved away from larger groups to a much smaller individualized approach, and we work at the moment quite successfully with high-risk networks to identify people in the community and to access their networks after we've gained their trust. Our program is doing well. We're achieving all our PEPFAR targets, and to some extent that allowed us, that combined with a very good monitoring and evaluation system, to really identify major variables that correlate with health. What came from, that's just images, photos of our work, our clinic, our doctor, that's our mobile teams in action. 2 of the major factors that we identified was unemployment and then mental health. And these things come with a lot of issues. Unemployment is high in South Africa. The country is not doing well. It's around 34%. And in our program, certain months, up to 70% of our clients are unemployed. Within unemployment, there are 2 very specific subgroups that's even more vulnerable. The first is MSM who use drugs. In South Africa, people might know about chemsex. That's usually organized around dating apps and middle-class men. What we find in South Africa and in Soweto, we work with 7 houses that where 2 or 3 gay guys live, and then men who have from the surrounding township come into those houses to have sex, very often also for exchange of money and drugs. So it's a funny interaction of MSM, drug use, and sex work. And the second group is the blesser-blessee phenomena, where about 60% of our clients have an age gap of 30 years and more between the sexual partners. And there's some economic motive, usually of the younger man being maintained and supported by the older man. So what we started, and all of this is pilots, and we're trying out things and trying to make sense. We have negotiated or have successfully collaborated with the City of Johannesburg, the local government, within 2 shelters to have specific dedicated spaces in 2 of the health regions. We also have monthly spaces where we take people on hikes or a movie just to take them for a moment out of the life of poverty and to see that, you know, life can be kinder. What has also been really working well that we want to expand on, because, you know, we're very informed by the Maslow hierarchy. You can't have a program that focuses on self-actualization that's on the top of the hierarchy if the basic needs of food and shelter is not met. And we, you know, if the government fails or life fails people, we have very limited capacity to address that, but we do feel that we do need to address that. So what we have started per health region, we have skill sessions where participants need to commit to four sessions where they get very, very basic skills like getting an email address, they get access to computers and the internet. We help them tailor-make their CVs and cover letters. And at the end of the session, each participant must submit 1 job application, 1 application for a skills development session, and 1 application for a learnership. And we can then also mentor them in that process. So far, this started in June this year, 216 men attended, and we've placed 31 people in jobs and learnerships. That is just some of our activities, again, our hikes, some of our social media outreach on this program. And then lastly, additional interventions. We do home delivery for medicines for homeless people. So we come to you and we deliver your meds. Collaboration is very important with local government, and our bulk of our funding is coming from PEPFAR, which goes a long way but doesn't really accommodate or allow for structural and mental health programming at this point. So our home deliveries, our retention went up from 60 to 80%. I must say, for us still, retention for unemployed men who have sex with men and probably the general population on ARTs is a very difficult area. In some of the regions where we mainly have drug-using clients, it's as low as 30%, where we're very good to get clients into care. We test them, they test positive, but on their 1 monthly or 3 monthly renewals, they've dropped out of care. And we're really struggling with ways to make that better. And then the collaboration with local government, and then alternative funding that we seeked, and we were lucky to get to do some of the pilots. And that's it. Thanks.
Thank you very much, David. Now we will talk about low-threshold housing as a powerful strategy for ending HIV epidemics, and it's going to be presented by Charles King from Housing Works. Charles, it's yours.
Thank you very much. I'm delighted to be here to speak with you about the critical importance of low-threshold harm reduction housing to end urban HIV epidemics. I am the Chief Executive Officer of Housing Works, which was formed in 1990 to end the dual crises of homelessness and HIV. We provide a wide range of services, but today I'm going to be focusing on housing, and in particular in talking about Housing Works, focusing on our supportive housing. So, why is housing so important? Well, Housing instability is a powerful predictor of HIV health outcomes, and we also know it's a manifestation of broader antecedent drivers of health inequalities such as structural racism, intergenerational poverty, mass incarceration, stigma, and systemic discrimination based on gender identity, sexual orientation, drug use, sex work, or other forms of marginalization. And we know that housing is a powerful intervention that will address not only HIV head-on, but also effectively address some of these antecedent events. So I want to talk a little bit about the research on homelessness and HIV and housing instability and HIV, as well as the outcomes from housing. So homelessness and housing instability places people at particular vulnerability for acquiring HIV infection, as well as making it more difficult to be retained in care and to benefit from consistent adherence to antiretroviral therapy, and results in premature mortality. So there have been 2 randomized controlled trials that consistently find that improved housing status independently predicts improved HIV health outcomes. These studies also importantly found that this was a cost-effective intervention, with the savings both from avoidable crisis care and savings from reduced new infections more than offset the cost of housing as an intervention. I also want to point out that housing is a powerful preventive measure to prevent people from contracting HIV. So most of the housing research has been done in high-income countries, but I do want to point out that there are examples, and they are shown on this page, that look at low and middle income countries that find exactly the same results. So given these findings, these dramatic findings, one must ask why we don't use housing more as HIV care, and why housing assistance falls far short of the actual need. In the United States, a large CDC study identified more than 20% of all adult people living with HIV had experienced either homelessness or housing instability in the prior 12 months. About half of these folk experienced literal homelessness. The others, for housing instability, what counted was doubling up or couch surfing, 2 or more moves within 12 months, or an eviction. The experience of homelessness and unstable housing obviously being an indicator of poor HIV health outcomes, you have to ask why we aren't doing more to address this. So let's look at some of the barriers. Obviously, one is the failure of governments to put up funding for housing. It's seen as an expensive intervention, though, as I say, the healthcare savings more than outweigh the cost of housing. But not only is there a lack of public support for housing, but in many instances, housing providers are resistant to housing people with a history of active drug use or untreated mental health issues. So these behavioral health issues become conflated and elevated above the goal of improving health outcome or ending HIV. So this ongoing stigma and marginalization of people who use drugs and have mental health issues have them deemed not housing ready. For that, we offer what is known as harm reduction housing, or a housing first model. So what is Housing First? For those who aren't familiar with it, it is a person-centered harm reduction framework for housing assistance that recognizes that placement in stable housing is not a reward for achieving health or other goals, but it's an essential foundation for individuals to begin to address their health issues. So housing, placement, and retention is not conditioned on sobriety or a commitment to compliance with medical or behavioral health treatment plans. Supportive services are voluntary, but actively offered, employing a harm reduction approach. And the other thing that I would point out is that what this does is lead to much more rapid stabilization and permanent decrease in homelessness than other models. So let's talk about what it looks like in a real life setting. So Housing Works has been providing low threshold harm reduction housing since 1990. We've housed and supported several thousand people. In supportive housing, our residents are entitled to privacy within their own homes. They have access to a range of supportive services and are encouraged to feel safe and share behavioral health concerns and questions without jeopardizing their housing security or being required to engage in any particular program. In fact, we established Housing Works because at the time in 1990, all other supportive housing programs required that you prove 120 days of sobriety before you became eligible for housing. We currently house 444 low-income New Yorkers with HIV who have faced barriers to care. So our harm reduction approach acknowledges that drug use is a part of some of our residents' lives and that housing assistance is necessary but not sufficient to ensure stable housing for many, and so we actively engage residents using motivational interviewing approach and encouraging support participation in a range of services. For example, we offer an undetectables program that provides financial incentives along with other interventions to achieve durable viral suppression. So who are the people we serve? Well, of our 444 residents with HIV, 68% identify as Black, 24% identify as Latinx, 35% identify as LGBTQI, 10% are young adults, 15% are transgender and non-binary, 77% have a mental health diagnosis, 57% are currently using substances, and over 60% are homeless at the time of admission. Despite all, the barriers that these folk face, throughout all of our housing, 88% are virally suppressed in the last 6 months, 83% over the past 12 months. This includes all residents, including people who are newly housed. For longer-term residents, we have viral suppression rates north of 95%, and 71% of our folk are vaccinated for COVID. So, I'm sorry, got lost. To summarize, both experience and empirical evidence underscore the role of housing interventions as a core component of plans to end HIV epidemics and address persistent and unacceptable HIV health inequities. By scaling up funding, prioritizing housing interventions, delivering a low-threshold harm reduction, housing-first approach, we can better meet the needs of all people with HIV by ensuring they are housed and able to ensure access. Thank you. I do have 2 slides of references. Sorry, probably won't see them up there long enough to take notes, but the conference has my slides, and I'm more than happy to make them available to everyone. Thank you.
Thank you very much, Charles. And so with that, we'll end the first part of that session, and I will ask Helen and Tanya to join me. So thank you again very much to our speakers. So welcome. Yeah, I can see. So we will start with Helen Olowefeso from the Fast Track Cities Institute. And Helen will talk about assessing health facilities, HIV-related stigma in the city of Lagos. The floor is yours, Helen.
Thank you, Pascal. With how long we've worked, I would expect my name to be said correctly.
It wasn't? I tried my best.
My surname is Olowofeso, so my full name is Helen Omowumi Olowofeso. I'm Senior Manager for Strategic Information at the Fast Track Cities Institute and IAPAC. Today I'll be speaking on assessing health facility HIV-related stigma in the city of Lagos and the documentation of findings from health facility administrators stigma elimination workshop, which we held last year. What you see on your screen now is essentially a summary of where we started in engagement with the HIV health facility administrators, trying to go from a place of low quality of life for PLs, depression, fear, low adherence, and suboptimal medical adherence to a place of zero stigma, which leads to zero HIV-related deaths, zero infections, zero discrimination, and also letting them know that all of this starts with healthcare providers within the context of health services. So as a general background, the Fast Track Cities initiative, generally Fast Track Cities around the world are working together to achieve all the goals that were outlined in the Paris Declaration. Most of us know that we just signed the Sevilla Declaration 2 nights ago, and as part of this effort, IAPAC has been working with selected Fast Track cities, including the city of Lagos, on a 15-city project implementing stigma elimination programs, which we started with a stigma assessment tool across healthcare facilities, which sort of informed an auto-generated action plan which addressed gaps. In terms of the action plans that each facility had generated, we had first evaluated equal access to care, confidentiality, safety infection control, training policies and quality assurances, which then informed an auto-generated action plan response, which I'm not going to get a lot into at this point. So this workshop for administrators in each of the cities was essentially a way to coordinate the process of assessing health facilities on how stigma influences the work that is being done and how to develop and implement a code of conduct and an action plan that the facilities can then implement. So within the context of this abstract, we had 74 healthcare facilities represented and 75 providers within the city. We had a 10-question stigma index scorecard, which was rolled out as part of the training. And in the scorecard, we had questions around staff training, labeling of HIV service locations within facilities, essential supplies for safety and infection control, examining relevant procedural guidance and policies within healthcare facilities, as well as community engagement in promoting stigma-free HIV prevention and care services. What you see on your screen now is the checklist, the tool that we actually use in doing this evaluation on stigma within the health facilities. We evaluated the facilities by the percentage of HIV staff who had been trained, who had access to certain facilities, and the percentage of all staff. Because what happens within the context of the city of Lagos is you have different levels of healthcare facilities. We have secondary level facilities, tertiary care level facilities, and primary level facilities. And in different settings, not every staff member is providing HIV services. So we wanted to evaluate how many percent of HIV core staff had received any form of training and had any form of the relevant tools necessary to eliminate stigma, and the percentage of all facility staff who were also in the same category. We then evaluated this scoring based on 100% proportion, with 22% being the cutoff point for 70% of health facilities being friendly. So in terms of the results, we had 19% of facilities, which is 14 of 74, which were all PEPFAR funded, achieve near stigma-free status, and we categorize near stigma-free status as scoring more than 70% on this checklist I just showed in the previous slide. 45% of the facilities reported that more than 50% of core HIV staff were trained on HIV service delivery, and only 21% of the facilities had more than 50% of all their staff trained in the delivery of healthcare of HIV facilities. We then had 92% reported having accessed essential supplies for safety and infection control. In terms of actual training, this table outlines the individual number of staff who had received universal precautions training, and we see that of the 74 facilities that participated, 54 of them, 54 of the facilities noted that all their staff had, all their staff had been, or more than 50% to 70% of the staff had been trained on universal precautions. I meant less than, I beg your pardon. And then it's also noteworthy that number of staff who had received training on stigma and discrimination reduction in healthcare settings was 70 of the facilities, had more than 50% of their HIV staff who had been trained. This is important because we had been implementing stigma trainings across a lot of these facilities, so these numbers made sense to us. However, you would also note that only 9 of the facilities had healthcare providers who had received less than 50% of their staff who had received HIV service training. 30% of the facilities reported having policies and procedures in place to register and address the complaints related to stigma and discrimination, and 34% of the facilities reported evidence of community engagement in promoting stigma-free HIV prevention and care. We found this a bit interesting because in a case where you have no opportunity to give feedback, there's not a lot of opportunities to report anything. And something that had to come out for a lot of the facilities as a result of this was encouraging them to put in place feedback mechanisms within the healthcare facilities, or put in place policies that encourage feedback so individuals, PLs could register whatever complaints they had. The graph here shows the number of health facilities who had observed the various metrics, indicators we're using to evaluate. So the graph on the right, you can see that 41% of them hadn't observed evidence of community engagement in promoting stigma-free HIV prevention and care services. 44 of them had no policy or procedure for registering and addressing complaints and grievances related to stigma and discrimination. But on the bright side, 60 of them had guidance in place on universal precautions at health facilities and guidance on confidentiality of prevention of HIV status at facility levels observed by 50 of the 74 facilities. The graph on the right shows that most of the facilities had a lot of the safety equipment that was necessary. However, we have 12 facilities not having observed supplies for safety and injections, and 10 of them having issues around sanitary staff and public wash areas, as well as instrument sterilization. So this graph is very important for me because it just shows that we have only 19% of the facilities that we can score 70% and above in terms of having an effective stigma elimination system, and we can see that 36% of the facilities scored less than 50%, and that means that there's quite a lot of work to be done. In conclusion, what we found out of this was including the stigma assessment toolkit in routine facility quality improvement, standard operating procedures will be very useful in creating avenues for self-reflection among facility level teams, and useful in stigma elimination processes at facility level if the healthcare providers are able to review their processes and reflect on the things that are happening within the healthcare facilities. We believe that a lot of the things that were going on leading up to the scores we were saying would be adjusted. And these baseline results shows that there's a need for more to be done to understand the gaps around what needs to be done to address stigma at facility level, and further assessment on the gaps and barriers towards eliminating stigma in healthcare facilities. And finally, there's a need for follow-up assessment. So we did this as a sort of a baseline back in 2021. And there's a need for us to do a follow-on to see where we are now from where we were at the time when we did this. This workshop was coordinated through the support of USAID and PEPFAR funds on the UNAIDS IPAC 15 City project. Thank you very much.
Thank you very much, Helen. And last but not least, Tanya Dietveld, also from the Fast Track Cities Institute. And Tanya will talk about stigma indicators in 25 European fast track cities. What are we measuring? What are we not measuring?
Yeah, so good afternoon, everyone. I'm the Regional Director for Europe for the Fast Track Cities Institute. And as I told someone earlier, in Danish we have a beautiful saying, when you're last, you're the raisin in the sausage end. So I hope I'll be a good raisin. And spoiler alert, it was 26, not 25 cities. Okay. But let me start the presentation by, I think, preaching to the converted. And that is by stating that HIV-related stigma is the main barrier to ending the HIV epidemic. And that means both in terms of epidemic control, but also ensuring the quality of life for people living with HIV. This is not a new realization to, I think, anyone here in the room, hopefully not at the end of this conference, and it's reflected in the multitude of international multilateral agreements to actually address HIV-related stigma, including UNAIDS global strategy that states that we want to have less than 10% of people living with HIV experiencing stigma and discrimination by 2025. However, where it's not reflected is in a standardized and validated accountability framework. There is, to date, one standardized and validated tool for measuring stigma that has also been endorsed by UNAIDS. However, it only looks at stigma in healthcare settings. Now, if we talk about the Fast Track Cities initiative, there are so many different programmatic interventions. We've heard some examples today to address HIV-related stigma, but again, no proper accountability framework. And we need indicators to actually measure HIV-related stigma in order to be able to evaluate our interventions, interventions in terms of their intended and unintended consequences. Of course, also to be able to compare stigma across contexts and also to evaluate the most effective models and bring them to scale. So, as the Institute, we decided to do a very simple survey in the fast track cities in Europe to look at what indicators are actually used to measure different domains of stigma. And if there are no indicators or metrics, why not? What are the main barriers? So we devised an online exploratory study consisting of 13 questions and disseminated it to fast-track cities across Europe, mainly to health departments, both at municipal, regional, and national level. And we disaggregated HIV-related stigma into 4 different domains, so structural, experienced, perceived, and internalized. So, as you can see from the responses, we had 26 fast-track cities that did respond, initially 87 respondents. We, however, ended up with a sample of 62 responses or respondents because there were some duplicates, some incompletes, and so forth. And we see that majority of the respondents were from municipal health departments or offices or health boards, depending on the health system in place in the country and city. Now, the questionnaire was very simply set up. So every question started out with, does your city measure or does your organization measure? If you got a yes, you were asked about indicators. If you said no, you were asked about barriers. So interestingly, the first question was about policies. Does your city have policies? Or are there policies in place that prohibit HIV-related stigma? And we see that majority of the fast-track cities, they did have policies in place. So far, so good. We would expect nothing less. But if we then start looking into measurements of impact or enforcement, you see that the numbers dwindle. quite significantly. So, for example, if we look at impact, 45% said no, they don't actually measure the impact of their policies. And as you see, 27% said they don't know. So combined, very high level of unawareness or lack of measurement of impact. The same for enforcement. Then we also asked about, well, do you or does your city measure the inclusion of people living with HIV in local governance structures? Again, as the Fast Track Cities Initiative and the Institute, we keep talking about community representation, community-led initiatives, and it's something that is important to a lot of Fast Track cities, but again, do we monitor it? According to this study, or this survey, no, 40% said no, we actually don't look at the representation. I found it interesting that one of the arguments arguments for why the representation of people living with HIV was not measured was that you cannot ensure the representation of everyone, but also if you see here the quote saying the city of course also trusts in the power of NGOs to bring forward the view of people living with HIV, which is an interesting observation or provides for an interesting insight in terms of where does the responsibility lie to ensure inclusion of people living with HIV, at least the perceived responsibility. For experience stigma, we asked if stigma is measured in healthcare settings, in the private sphere and in the public sphere. And again, we see very high levels of no, that it's not actually measured. So the least measured being in the public sphere, followed by in the private sphere, so for example by friends, partners, family members, and lastly then healthcare settings. Perceived stigma, I should probably say one small note here, it's not perceived stigma of people living with HIV, but it's perceived stigma by the public. So does the public consider there to be stigma towards people living with HIV? And also do healthcare workers report observations of HIV-related stigma? Again, we see no, that's actually not something that is routinely measured. And lastly, the last stigma domain that we asked about was internalized stigma, which is something, again, we talk about a lot, and it's, of course, to a great extent, a result of the other stigma domains. Here, as well, we see that 61.5% say no, we don't actually measure internalized stigma. And in contrast to the other areas, if we look at barriers, the number one barrier here was the lack of human resources to actually conduct the monitoring and measurement of internalized stigma. Whereas with the others, it would typically be either the lack of standardized or validated indicators or the lack of organizational capacity to actually conduct monitoring. So, if we look at the main findings of this survey, well, first, as you saw from the sample size, also the disaggregated sample size, there was a low response rate. Some of it could be the usual suspects, such as the timing, the mode, the length, could also be survey fatigue. But I would also harness a guess that it has to do with, again, there was higher levels of unawareness of metrics being put in place or being in place at city, regional, and national level, which meant that also a lot of the questions were skipped. If we then look at the domains measured, again, there doesn't seem to be much disaggregation of stigma into different domains, and as you saw from the results, the least measured is the perceived stigma, so by healthcare workers, experienced stigma in the public sphere, and internalized stigma. And we also see a massive gap between the policy level and, again, the measurement of impact and enforcement in practice. Then one thing we asked, of course, cities about as well as a part of the survey was, well, do you actually think there should be standardized and validated indicators? And we do see a very high agreement on that note. If we look at the main barriers of why HIV-related stigma is not measured in the respective fast-track cities, we see that number one is, again, the lack of validated and standardized indicators. Number two, lack of organizational capacity to actually conduct conduct monitoring, and number 3, lack of human resources. And I must say, on a personal note, I was a bit surprised here, because one of the options was also lack of dedicated funding, which I thought would have come out on top for each of the domains. It was not. It was always factored there, but usually in the number 5 or 4th or 5th barrier. So, what does that mean? Well, of course, we stay committed to attaining the Paris Declaration's commitment to achieving zero stigma and discrimination, as well as aligning with our colleagues at UNAIDS. We do see, however, there is a scarcity of validated and standardized indicators. That means we cannot track our progress, and we can leverage the findings of these surveys for our future work. So some of the potential next steps would be to modify and refine the survey, and then have it across the Fast Track Cities network globally, and not just focused on Europe. Increase the capacity trainings on stigma monitoring and evaluation. As Helen just presented, there is work ongoing, but clearly there's a higher need for it. But also look into mobilizing resources to actually set up a designated task force to develop standardized and validated indicators that can be used across the Fast Track Cities network globally. What could Fast Track Cities do? Again, of course, we don't impose or prescriptive, but based on the high levels of unawareness of existing metrics at city or regional or national level, a recommendation could be to see if there are any. If there are, then share with the Fast Track Cities Institute, and also share with affiliate Fast Track Cities. And of course also, which I think most organizations and cities already do, but try to mobilize resources to increase the human capacity and organizational capacity to actually do targeted, dedicated stigma monitoring. Thank you.
Thank you very much, Tanya. And so on that, we will be closing this oral abstract session. If you have any specific question, please feel free to approach the speakers. I'm sure they'll be happy to respond. And we will also encourage you to join us for the closing session upstairs, which will start in a couple of minutes. So yeah, and on that, have a great end of the day, and take care. Thank you.